All right, welcome back to another PCBH Corner. I'm so excited to be joined by Alan Francis, who probably many know, that has done a lot of different writings. I got to know him by his book, Saving Normal, that I'm hoping to talk a little bit about. And I know we're kind of on a time we want to make the most use of this. So, Dr. Francis, I wanted to jump in. And my first question is probably a big question that I'm excited to see where your mind goes is, after reading that book, Saving Normal, throughout this, I kept asking, like, what was the moment that you realized we might be getting this wrong, or we might be heading as a field of psychiatry, of psychology, and particularly with diagnosing, then we might be heading to a place that is getting to be unworkable, that we might be going down a path that we don't necessarily want to be going down. When was that moment that you realized that?
Well, he was a resident in the late 60s, and we were way over-diagnosing schizophrenia and giving people enormous doses of antipsychotics, keeping them in the hospital for a really long period of time, warehousing them. And in 1982, I wrote a paper called No Treatment as the Treatment of Choice. So that even though I was part of DSM-3, I was always sort of the skeptic on the overuse of psychiatric diagnosis. I always felt we should underdiagnose rather than overdiagnose. It's always easy to increase the severity of a diagnosis. Once a person gets a label, it haunts them for life. That overdiagnosis leads to tons of medication that people don't need. So I've been a kind of cautious. I have great respect for diagnosis, and I spent a lot of my life working on it. It's done well, done accurately. It's life enhancing and sometimes life saving. But overdone and done carelessly, a diagnosis can lead to as much tragedy as the underlying disorder. And so my emphasis is on cautious, careful, conservative diagnosis.
So let me ask you this, because you talk about this in the book when you oversaw the development of the DSM-4, about what your hope was for the DSM-4, and then the rippling out effect that just was unintended. And then obviously the DSM-5, unfortunately, maybe having that even worsen. For people working in primary care, which, as we said, is the audience that largely works in it. Primary care, as you know, it's fast-paced. It's where the majority of people that are receiving psychotropics get prescribed. A lot of diagnoses are rendered very quickly. What advice would you give people that are working in primary care to not continue to maybe have this tendency of overdiagnosing?
I think primary care is really the main arena for psychiatric care. So 80% of psychiatric medications are given in primary care. Only 20% of psychiatric medications are given by psychiatrists. And particularly benzodiazepines, 90% of benzodiazepines are given in primary care, 80% of antidepressants, 60% of antipsychotics, and 50% of stimulants are given in primary care. So really, primary care is a much more important arena for psychiatry than specialty psychiatry. So I couldn't emphasize enough how important is the work of the people that you're helping to educate. I think that primary care is also the hardest place to diagnosis. It's the hardest place partly because there's the least time. It's the hardest place because the primary care docs themselves usually have not had much training in psychiatry. It's the hardest place because they only have 15 minutes for or less, and they have to fill out records for each patient, and they have to get the patient out happy. And the easiest way to get the patient out happy is to write a script. The hardest because most primary care practices don't have behavioral health components. Your people are doing a very important service. In many practices, that service is just completely unavailable. It's the hardest because there's no harder place to make a diagnosis than in primary care. That I've seen hundreds and hundreds of patients who got a psychiatric, maybe thousands of patients who've gotten a psychiatric diagnosis who didn't need one. Many of those patients got that psychiatric diagnosis in primary care. The quick and careless default psychiatric diagnoses when there's medical uncertainty is a global problem in our system, that if the doc can't explain it on medical grounds, the assumption is always, well, it must be in your head, it must be a psychiatric problem. On the other side, very many problems that look psychiatric are really medication or medically induced. My first thought with anyone who has a fresh psychiatric symptom who's on medication particularly in the elderly, is it's a medication side effect.
Ah, interesting.
Much more likely for an elderly person to have a late onset of medication-induced psychiatric symptoms than for it to be a primary psychiatric disorder. And my second thought is going to be medical problem. I will be thinking of a primary psychiatric disorder as only a third possibility in anyone, past, youth, because so many people are taking drugs for medical problems that cause psychiatric symptoms, and because medical problems become more and more common as people age.
Dr. Fritz, I love you saying, because this is something that we talk about with both our psychology trainees and our family medicine residents, the importance of understanding base rates about what most likely is producing something or being seen. And I love how you've been saying that, like when I start to see symptoms at a certain age, this is almost the algorithm that I'm going through to make sure I'm ruling out what is the more likely thing rather than a psychiatric diagnosis of what's going on. I love that you said that. That's great. So for you, it seems like the suggestions for people working in primary care is maybe slow down a little bit. Don't give this diagnosis
Or maybe
automatically.
a lot. I mean, I think that in the two age groups, in terms of base rates, where diagnoses are most often wrong are kids and the elderly. So in kids, there's a huge tendency to way overdiagnose. So many of the problems in kids are due to acute stressors, environmental difficulties, family difficulties, school bullying, all sorts of problems that kids have get translated into, oh, they have a severe psychiatric problem, where very often they'll be outgrowing it, either because they've outgrown the situation or because life experience has made them less shy or less impulsive. And that overdiagnosing in kids is particularly bad because they get medication they don't need, and they get the label often for life that will do much more harm than good. And similarly with the elderly, the idea that most problems in the elderly are caused by new onset psychiatric disorders is wrong. Most psychiatric problems in the elderly are caused by medication or medical side effect of the illness. And so being aware of the fact that not everything that looks like a primary psychiatric problem is a primary psychiatric problem, underdiagnosing, taking time. You can't do an evaluation in 15 minutes or 45 minutes. You can't do an evaluation one visit. That very often you have to take the time of seeing someone over a number of visits before you can make the diagnosis. And the trouble with the insurance system is that it tends to force a diagnosis well before a person could reasonably and carefully make one. This is crazy for the insurance companies, because what happens is that people jump to diagnoses and to treatments that will maybe take years of medication and visits. It's expensive to overdiagnose, and forcing diagnoses early forces overdiagnosis and overtreatment. It would be much smarter if they paid more for evaluation visits, so that you wouldn't have to have a diagnosis. We're evaluating an individual, very often 3 or 4 visits, evaluation visits, and you realize that the psychiatric problem either doesn't exist at all or is transient, and that you won't need medication for a lifetime. The advice, psychotherapy for most mild to moderate psychiatric problems, the use of advice, normalization, psychotherapy is much cheaper in the long run than starting a pill. It's very cheap and easy to start a pill on a first visit, but then the person may be taking that for years or decades, getting side effects, no positive effect, and all the expense of those visits. Psychotherapy and advice and normalization given at an appropriate time, most people who come in with this acute stress problems will get better on their own.
And I love the research that's coming out a lot from Europe, that thankfully is starting to infiltrate some of our point of care resources, like up to date about watchful waiting, right? Which really is almost kind of like active waiting, as you said, like normalizing, maybe giving some, setting some goals, and particularly for mild and moderate depression, people get better. It just, the symptoms largely resolve after that.
The placebo response rate for severe psychiatric disorders is under 10%.
Huh.
The drug response rate may be 40 to 50%. So you're getting like a 4-to-1 advantage to active medication with real psychiatric problems. For mild psychiatric problems, the placebo response rate is over 50%. The active drug response rate may be 70%. So you're getting a very tiny advantage of active drug over placebo, but the patient doesn't know that. So if the doc sees the patient for 15 minutes, it's on the patient's worst day. That's when people come to doctors. The patient leaves the office with the medication. The odds are at least half they're going to get better in 2 weeks without the medication. But once they take the pill, they will attribute the benefit to the pill rather than the passage of time. And they'll feel that they have to stay on the pill to stay well. Sometimes the person stays on the pill long enough to have withdrawal effects if they stop it. And if they have withdrawal effects when they stop the medication, they'll assume that it was a relapse of the original problem, not the withdrawal effect of the medication. So it confirms the idea that the pill is crucial to their existence. So you get many people who come to the office with a problem that would get better in 2-3 weeks on its own, placebo effect, expectations, passage of time, removal of stress, support, that doesn't need medication, absolutely doesn't need medication. But a month later, when they've taken the pill, they'll say, oh, the pill made me better.
Right.
And 2 years later, when they try to stop the pill, it may have withdrawal effects. And when they feel symptoms again, they'll say, aha, I'm sick. The pill made me well. I have to stay on the pill. So many people stay on pills for years or decades who never really needed them. It's important to use pills as a last resort with mild to moderate problems, to do the advice, normalization, support, parent training, psychotherapy first, and a pill only as the last resort. And that gives time also for the placebo effect to kick in, because all of this attention will help people get better on their own. Time will help them get better on their own. And then you're not forcing them into years and years of treatment.
Again, you're getting me hyped with all these different things that you're saying. I'm so excited for the viewers to watch this. Two additional questions my mind went to. One was, what do you make? And I know you wrote a blog post about this, particularly with the guidelines that came out about potentially screening children for anxiety, about what the ripple effect of that's going to be. What do you make of a lot of these guidelines that come out, particularly that get enacted in primary care about screening people for specific symptoms and pathologies, and now are even part of like quality aims and metrics that healthcare centers have to do? What advice would you give health centers that, hey, yeah, this is recommended, these are the guidelines that are coming out, but make sure that we don't use it in a way that continues to go down this road that we know isn't workable?
I think a lot of the guidelines for universal screening, especially in kids, are just crazy. One of the things I've learned is you can't trust experts to make guidelines in their particular area, because they will always expand their area. They will always see the benefits of what they're doing and expanding their diagnosis. They'll never understand the risks and unintended consequences. They never work in primary care. No expert in psychiatry has spent a lot of time, very few have spent a lot of time in primary care. They decide things based on their own experience in research clinics that are highly specialized, have lots of time with each patient, have highly selected patients. The patients who get to see experts are very different than the patients who are seen in primary care. The base rates of disorder in a expert clinic is going to be very high. The true base rate of a disorder in people presenting in primary care is going to be much lower. You make many more errors, false positive diagnoses in primary care with the same guidelines that may work in an expert clinic. So the problem with universal screening of kids is that you get an enormous number of false positives. Enormous number of false positives. And a false positive can be a very dangerous thing, because it leads to labeling the kid, stigmatizing the kid, and worst of all, often giving him medication. So I'm very much for screening in high-risk populations.
Gotcha.
Pregnant women who've just delivered kids with a high incidence of psychiatric problems that can be harmful both to mother and child around pregnancy and childbirth. That's a perfect place where a primary care doc should be asking every woman about psychiatric symptoms on every visit during the pregnancy and after the birth, to make sure that she's not going to get a depression or a psychosis that may be very harmful to her, very harmful to the child and to their relationship. High risk population, high base rate of problems, terrible consequences, all make screening useful. When you want to screen every kid in the world, every child, the screenings are recommended at ages in some places